Now we're going to talk about Chapter 13, which is planning, and that's our next step in the nursing process. Now, planning is deliberate, it's systematic, and it's the problem-solving phase of the nursing process. That's where you're going to create your nursing interventions, and that's the treatments that a nurse performs to enhance a patient-client's outcome, because we want them to have an improved client outcome. The nurse is responsible, but input from the client is essential. That goes back to the assessment. You're going to have input from that client. And you're also going to make sure the client's on the same page as you as far as what your plans are. Now, planning begins with the very first contact you have with your patient. It continues until the nurse-client relationship is ended. They are no longer under your care. It's multidisciplinary because you're not the only one caring for that client. It is initial planning, and that's develop initial comprehensive plan of care, and it's begun after the initial assessment is completed. Ongoing planning is done by all the nurses who work with the client. Individualization of the initial care plan. Every care plan is individualized specifically for that client's needs. And at the beginning of a shift, when you come into work, you determine whether the client's health status has changed. And then for each shift that you work, for all the care that you provide, you have to set priorities for your client's care during that shift. So at the beginning of a shift, you're going to decide which problems to focus on, and then you're going to coordinate your nursing activities so that more than one problem can be addressed at each client contact. So you have to be very organized to effectively give needed care to enhance the client's outcomes. We also have discharge planning, and that's just the process of anticipating. You're figuring out what needs to occur for their needs after they're discharged, whether they're going home to another level of care, to a residential facility in a community. So it's addressed in each client's care plan, ongoing discharge planning. The old adage is discharge planning begins on admission, and absolutely it should, because it's comprehensive and it involves an ongoing assessment to determine how do they go home successfully or to their next level of care. So in the phase of planning, it's the third phase of the nursing process, and in this phase the nurse and the client develop client goals, desired outcomes, and nursing interventions to prevent, reduce, or alleviate the client's health problems. So what exactly are we doing? 4 main points, write them down. We prioritize their problems and their diagnoses in order of priority. We formulate their goals and their desired outcomes. We select nursing interventions, and we write those nursing interventions. When we first get started, we're looking at an informal nursing care plan. It's a strategy for action that exists in the nurse's mind, so it is mental work. It begins in your mind. And then we move into a formal nursing care plan when you write that down, or use a computerized guide, or you input it electronically into your healthcare system. And then we have a standardized care plan, and that's a formal plan that specifies actions for a group of clients with common needs. So let's say that you are on a hospital floor and it's a pulmonary floor and you have many patients with COPD. You might have a formal care plan that's listed in a computer or it's pre-printed for that group of clients because their needs will be similar. Then we have an individualized care plan, and that's tailored to meet the unique needs of a specific client. We establish a care plan to ensure minimal criteria for care are met, and it also establishes how we're going to use our time so we have an efficient use of time. We can't just hang on by the seat of our pants. We have to know what we're doing to provide care. If you don't have a plan, you cannot reach a goal, and your client will not improve. Then we have standards of care, and standards of care are nursing actions for clients with similar medical conditions. And what standards of care really do is they list achievable rather than ideal nursing care. What's truly achievable with this group of clients, and it's interventions for which nurses are accountable. And usually there are agency records that may be referred to in the client's care plan. Standards of care are always going to be written from your perspective, the perspective of the nurse. and your responsibilities, and it does not contain medical interventions. And there's examples of these in your textbook. Please refer to that. And then we have standardized care plans, and that's pre-developed guides for nurses caring for clients with a need arising frequently in an agency, and written from the perspective of what care the client can expect to receive. So that's a standardized care plan, and that's a guide that's already developed for nursing care of clients with frequently the same problems. A lot of times we see standardized care plans maybe for a physician and all the clients admitted under a physician, and they're for things that happen frequently. That might be, what are we going to do in case if someone has diarrhea, someone has constipation, someone has nausea, someone has pain, so that we automatically know what to do and we get the orders and we implement the care. Okay, this is figure 13.4, and this is a standardized care plan for the nursing diagnosis of deficit fluid volume. And we can see etiology, we can see what the desired outcome is, the nursing intervention, and the defining characteristics. And as we move a little further, we're going to talk more about what each of these elements really mean. Then we have protocols, and protocols indicate actions commonly required for a particular group of clients, and that can include both primary care providers' orders and nursing interventions. An example of this is a protocol for admitting a client to the intensive care unit. Then we have policies and procedures, and those are things that are just developed to govern the handling of frequently occurring situation in a clinical area. And it covers situations pertinent to client care. An example of this is policy specifying the number of visitors a client may have. Now, these policies and procedures, they are agency specific, and all this information is readily available, so you know what the policies and procedures are that govern your ability to work. We also have standing orders, and these are written documents, policy, rules, regulations, and orders regarding patient care. And it gives the nurse authority to carry out specific actions under certain circumstances. If you have a patient who has difficulty breathing or their oxygen saturation level is a little low, most standing orders give nurses the ability to go ahead and implement 2 liters of oxygen through a nasal cannula. But depending on where you are and what population you're with, your standing orders will reflect your population. Then we have where you individualize the standard care plan, just so that it fits your client. And it's usually both pre-authored and nurse-created sections. And this is what you're going to find in a hospital when you're working. When you're a student, you do create everything from scratch because it's part of the growth process, part of learning. But when you're actually working as a nurse, you don't have time to look everything up. And these pre-authored sections are for predictable, commonly occurring problems, and individual plans for unusual problems or problems needing a special attention. So we have 2 different types for predictable, commonly occurring problems, and individual plans for unusual problems. Then we have a student care plan. The rationale for creating a student care plan is so that you understand the evidence-based principles for why you are doing a particular nursing intervention. And remember, every intervention that you do for your patient, it will have a scientific underpinning for why you're doing it. If you have a patient that has edema in the lower extremities and you elevate their legs, you know, because scientifically and evidence-based, we know that promotes venous return to the heart. So anytime that you write an intervention, know that you're going to list what's the evidence, why are you doing this. Another type of student care plan is a concept map, and that's just a visual representation of a care plan. And depending on how your brain works, some people see things better more linear, and other people with a big map. In the next slide, you're going to see an example of a concept map. So then we have computerized care plans, where we can create and store nursing care plans through a computer, and these can be accessed through the nursing station, through the nursing computers, and appropriate diagnoses are selected from a menu suggested by the computer, which simplifies nurses' ability to make care plans quickly. Then we have multidisciplinary collaborative care plans, also known as a critical pathway, and that really just sequences care that must be given each day during a projected length of stay for each condition. It's usually organized with a column for each day listing interventions and outcomes, and it includes medical treatments to be performed by other providers. So really, we look at this as just a holistic way to make sure that all care is included and then we're not being fragmented for your patient, because everything's listed that's going to occur each day for your patient. And really, all this goes back to Medicare and Medicaid guidelines, which only allot for the patient to be in the hospital for a certain time period for different diseases and disorders. This way we make sure we're hitting those time frames and we're progressing the patient as quickly as we can to a healthy outcome. We always date and sign the plan. Depending on your facility, it could be in writing, even though we're very quickly getting away from that and most things are computerized. We use category headings. You always make sure you're using standardized and approved medical or English symbols and keywords rather than complete sentences to communicate your idea, unless your agency policy dictates otherwise. And be specific. Recording information, care plans, it is not an exercise in really English. It's an exercise in being very concise and getting your ideas down in a standardized way. You're also going to refer to resources, procedure books, or other sources of information rather than including all the steps of a written care plan. This is when you are in a hospital. If you are writing your very first nursing care plan or you are in nursing school, you're going to write it all down. And make sure the plan is individualized for your client, meeting their needs in a way that they find acceptable. And also, in addition, you need to make sure that your nursing care plan incorporates prevention and health maintenance aspects as well as restorative ones. So yes, we're taking care of their problems, but we're also making them healthier in the process. We're using aspects of prevention. We don't want another problem to begin. And we also want the health status, their strengths, to remain strong. We also ensure that the plan contains ongoing assessment of the client, because that is vital, because we are required by law to have continual assessment. We also include collaborative and coordination activities in the plan, and include plans for the client's discharge and home care needs. So who are we collaborating with? Who is coordinating the care? Generally the registered nurse. And then what are they going to need when they leave? And are we making sure that those things are available to them? So the things we're looking at in the planning process is, one, we're going to set priorities. We're going to establish client goals or desired outcomes. Or another way to say this is, what do we want to happen for the client? What is our desired outcome? What is our goal? We select their nursing interventions, and then we write individualized nursing interventions based on a plan of care. When we set priorities, we base them on high priority, something that's life-threatening, medium priority, that's health-threatening, it's something we're going to address, but it's not life-threatening. And then low priority generally refers more to developmental needs, things that happen throughout the lifespan. Some of the factors that we consider: what is your client's health values and beliefs? You need to make sure you're somewhat on the same page with the client. Your plan won't be successful if they're not on board. You should make sure that your priorities are your client's priorities, or your plan will not be successful. And make sure that your resources are available. If your client's being discharged and they don't have available resources, what you want them to do, they may not be able to do. We also set the priority based on the urgency of the health problem and how their medical treatment plan is factored into that. We would never do something that's contrary to the medical plan. So we establish goals and desired outcomes. Now, there is a difference between goals and desired outcomes. A goal is simply a broad statement about the client's status, but our desired outcome is really more specific. It's observable criteria used to evaluate whether goals have been met. If you have a patient that has been immobile or they have difficulty moving, you might have the goals that the patient's going to be able to move more freely, but your desired outcome is going to be specific. It's going to be observable criteria. It's going to be measurable, and they might be able to walk 5 feet without assistance. This slide is deriving desired outcomes from nursing diagnoses. Let's just say that our nursing diagnosis is impaired physical mobility, and that's going to be the inability to bear weight on left leg related to inflammation of the knee joint. Our goal is going to be improved mobility ability to bear weight on left leg. And you see, that's very broad. Just improve mobility. We can't measure that, but that's our goal. But our desired outcome is specific. The patient will ambulate with crutches by the end of the week, stand without assistance by the end of the month. Ineffective airway clearance related to poor cough effort, secondary to incision pain and fear of damaging sutures. That's our diagnosis. Our goal, which is the opposite healthy response of that ineffective airway clearance, is our patient's going to have effective airway clearance. And our desired outcome, which is very specific, is they're going to have clear lungs to auscultation during the entire postoperative period, or have no skin pallor or cyanosis by 12 hours post-operation, demonstrate good cough effort within 24 hours after surgery. So we have our nursing diagnosis, our goal, which is it's the opposite healthy response of the nursing diagnosis, and it's very broad. Then we have our desired outcome, which is very specific, stating exactly what our client's going to do, and it's always measurable. So the purpose of the desired goal or outcome is to provide direction for planning interventions, and it serves as the criteria for evaluating progress. It enables the client and the nurse together to determine when a problem's been resolved. Because if your client, their desired outcome, they have met that criteria, that problem is resolved. And it helps to motivate the client and the nurse by providing a sense of achievement. They want to reach their goals. You give someone a goal, they want to reach it. So we have short-term and long-term goals. Short-term goals, just by their very nature, they're short. It might be something over the course of a week, a few days. And short-term goals are useful for clients who require health care just for a short period of time. Or sometimes people are just frustrated by long-term goals that seem difficult to achieve, and they need the satisfaction of achieving a short-term goal. The relationship of the goals and desired outcome to the nursing diagnosis. Your goals are derived from your diagnostic label. Your goals come directly from your NANDA label. And your diagnostic label contains the unhealthy response, and your goal is simply the opposite healthy response. Now, the relationship of the goals and desired outcomes to a nursing diagnosis. How the client will look or behave if health response is achievable. Observable, time limited, and that's achieving the goal demonstrates resolution of the problem. So if we said that relationship of the goal or desired outcome to the nursing diagnosis, if we said that they had impaired mobility and our goal was to ambulate 5 feet by 3 p.m. today, they ambulated 5 feet by 3 p.m. today, we can say that problem is resolved. We do have components of the goal desired outcome statement, and these are things you need to commit to memory, because every time you write that desired outcome statement, you're going to include these elements. One, you have the subject, and the subject generally is the patient will. The patient is your subject. The verb, it's what they're going to do. Then we have conditions or modifiers, and then the criterion of desired performance. Let's say that the subject is the patient will. The verb is the patient will walk 10 feet. The condition or modifier is without assistance. And criterion of desired performance is they'll do this by 3 p.m. So if we put all of that together, the patient will walk 10 feet without assistance by 3 p.m. So it's very clear, it's very specific, it's very measurable, and it's within a given time frame. So we do have guidelines for writing goals and desired outcomes. It has to be written in terms of the client's response, and it has to be realistic. If you have something that's unrealistic, they're never going to meet that. And you have to make sure it's compatible with therapies of other professionals. You would not state that the client's going to walk 10 feet if you know they're on complete bed rest and they can't get out of the bed. So we have to make sure that what we're doing, it makes sense for the client. So our guidelines for writing goals or desired outcomes, they're derived from only one nursing diagnosis. So generally you have a nursing diagnosis and then a goal desired outcome. It uses observable, measurable terms, and you make sure the client considers the goal important, because if they don't think it's important, you're not going to be successful, you're not going to reach it, because they're not going to care. The action nurses perform to achieve a goal, and it focuses on eliminating or reducing the etiology of the nursing diagnosis. So whatever the cause is, the thing that's causing the problem, we're trying to reduce that. We treat the signs and symptoms and defining characteristics, and interventions for nursing diagnosis should focus on reducing clients' risk factors. We're always looking at risk factor reduction. We've already sort of mentioned this, but types of nursing interventions, we have independent activities. These are things that registered nurses are licensed and it's within their scope of practice to initiate or to do for the patient. And those things include things like physical care and ongoing assessment. Then we have dependent interventions, and that activity is carried out under a doctor's order or supervision or according to a specified routine. Those are things like giving medications, doing specific wound care, IV fluids, inserting catheters, NG tubes. So we also have collaborative interventions, and that's actions nurses carry out in collaboration with other healthcare team members, and that reflects overlapping responsibilities of the healthcare team. We also have to consider the consequences of each intervention and choose those that are more likely to help your patient be successful in reaching their desired outcome. That requires for you to have nursing knowledge and experience. That's one of the reasons you go into clinical, is to build that nursing knowledge and experience, because every patient you care for, you've learned something about a disease process and about how we care for patients with those problems. Criteria for choosing nursing interventions: one, it has to be safe and appropriate for the client's age, health, and condition. It has to be achievable with the resources that you have. And it has to be congruent with the client's values, beliefs, and cultures. If it's not, you're not going to be successful. And it has to be congruent with the other therapies they're receiving. It needs to be based on nursing knowledge and experience, or knowledge from relevant sciences. It's not just up in the air. It comes from a specified source, and it's within established standards of care. When you're writing an individualized nursing care plan, you always have to have a date. This is a recap. A verb, the patient will, action verb, starts the intervention and must be provided. The patient will walk without assistance. Conditions: 10 feet by 3 p.m. today. And that covers all of those components. And it's really just as simple as that. You're stating what they're going to do in an order that's clear, specific, measurable, and always gives a time frame. So clear, specific, measurable, within a given time frame. Just commit that to memory. That's going to stay with you. So what's the relationship of nursing interventions to the problem status? One, it's your observations. It's your prevention interventions. What are you doing to prevent? What treatments are you doing based on orders? And it's enhancement or promotion of interventions. What are we doing to add to their health and to achieve their health status and health outcomes? We also delegate during implementation. Delegation occurs during planning. Who is decided to do each task? The nurse is responsible for the correct implementation of tasks delegated, analysis of data, and evaluation of outcomes. So let's just say you delegated to another nurse, to an LPN, to take the vital signs. Those vital signs were taken, they were recorded, and they didn't fall within a defined range. So let's just say the blood pressure was extremely high. You didn't go back to check to see what it was. Whose fault is that? It's yours, because you might have given the task to someone else, but you are still responsible for the outcome and the evaluation. So remember, anytime that you delegate something, the responsibility rests with you. So when looking at the nursing intervention classification and just wrapping up this lecture, what's important to remember is that there's more than 542. You'll find some of these in your textbook. You'll find them in nursing care plan books, and they all come from the North American Nursing Diagnosis Association, and it always includes a label. That's the name, that's the NANDA. It always includes a definition and a list of activities that outline key actions, and these activities are your interventions. These are the things, evidence-based, that you do for your clients to help them reach a positive outcome. Remember, that's the key. We always want patients to have an improved level of health. They're always linked to a NANDA diagnostic label. Then we select the appropriate interventions and we customize, so it's holistic care, customized, individualized for your patient's specific needs, because all patients, regardless whether their diagnoses are the same, their needs will vary. Thank you.